be talking about change in OT practice during COVID, and there's been tremendous change in the COVID practices, the OT practices during this time, and we have had a very tough time in the last 1 year, which is actually tough on both the practices and financial aspect. So disruption by COVID-19 in April 2020 was 95% reduction in the OPD and 99% reduction in IPD. And we were running only the emergency OPD and OT services. Now, even after second phase or second bout of the COVID-19, OPD is 50% and IPD is still 30 to 40%, which is still, the tough time is not over. Now, okay, I have to, kind of take it out from here. Okay. So, all people who were patients who were coming in the hospital, they were scanned, and if there's a fever detected, they cannot enter and sent to bigger COVID center. Basically, they should be recognized and confirmed by their mobile numbers, especially with the AIOS app, which was they were asked to download before entering the hospital. We did not do any routine OT to about 4 weeks, and it was gradually increased. So 3 to 4 quarters, I remember, we thought that it will be back to 50%, and it is about a year. Still, we are not 50% totally. And they were very skeptical about health and finance, and impact is absolute. And the most things, related to cataract and refractive are really pushed back. And since I'm a cataract and refractive surgeon, the financial impact was really very high. And retina was first to start because it was always an emergency, and patient had kind of difficulty, big difficulty in seeing and doing things. All known or suspected COVID patients requiring surgical intervention must be treated like positive until proven otherwise. And majority of key management roles were given to the senior staff and not to all of the staff members. And we did not take any GA patients. Change to scrubs in the hospital, that is still the norm, and PPE for staff at risk, and the gown, the cap, mask, gloves, protective glasses, shoe covers, they were given, and they were removed while leaving and not disposable, put in 0.5% sodium hypochlorite and washed the same day, and then next day they were changed. Necessary PPE was FFP2 or 3 masks in high risk cases, and disposable waterproof gowns, double gloves, which we still practice, protective goggles, visors, shoe covers, caps. Patient is also still going in with the mask, though I have seen that couple of patients, when they're lying down while doing cataract surgery, the carbon dioxide and carbon monoxide buildup in the mask is very high, and sometimes the patient have some difficulty while waking up after the surgery, even when it is 10 minutes of surgery. Negative pressure OT, which we all have, and minimum movement of the staff, all disposables, and like me, the beard should have mask with adequate cover so that there is no air exchange in the OT from me to others and others to me. Only daycare surgeries or emergency surgeries, in all those cases which were brought in for surgeries, had chest x-rays, and we were only working during routine hours. In fact, less than routine hours. From the normal routine hours for our center was 8 to 7. We are working from 10 to 2 initially, and now 10 to 4. All surgeries were done by the senior team for quick and safe surgery and with the minimal staff. Choose the quickest possible surgical procedure where you are most comfortable, and topical anesthesia, absolutely no general anesthesia, basically in initial phases, because general anesthesia, there was a lot of and no positive pressure in OT during and up to 20 minutes after. So, and smoke evacuation after diathermy, and aerosol generating procedures such as intubation, extubation, cautery should be done with the full PPE. And between the two surgeries earlier, we were keeping a 20-minute gap and changed everything, but now it is no more practice. 20 minutes we do not, and we do a gap of 10 minutes where we change everything. Okay, sorry.
Now you can continue, sir.
Yeah, because I think it was 10 minutes. It's still
Yeah,
5 minutes over.
5 minutes, sir. Yeah.
Yeah. So disinfection of OT, the protocol, and as I said, and HCQS we started initially, but then they proven the efficacy and everything necessity was not seen, so we stopped it. Immediately we were not keeping a long list. Now, since the people have taken enough precautions, we are trying to keep long lists also, but not like more than 10 cases. And even then, sometimes we want to keep lesser than that. Um, Right. And the most important thing was the staggered cases, like how many cases you can do and how many long and short cases you can do. And if we want to do longer hours, then 2 or 3 teams were, used, and, minimum number in the OT, but maximum number of OTs where we take minimum number of cases. We postponed all the infected GA and camps. Absolutely no camps in last 1 year, as everybody is clear about it. Counseling is very important with the patient and the attendant, and the special consent given by AIOS we are using, and at least 12 hours before we gave the consent to the patient to read at home and bring next morning for signature. Basically, well-established plans to perform undeferrable surgical procedures and emergencies on COVID-19 positive patient is mandatory. And we prepared specific internal protocols and arrange adequate training of the involved personnel for these COVID tough times.